So now the question arises that how we should prepare. So these guidelines have been taken from MRCPI info from the RCPI website. They say that you should give it enough time, and you should spend like at least 3 months on preparation of this exam. As you know, the slots are limited and number of attempts is also limited, so you have to do your best. So prepare very well, and when you are preparing your study plan, make sure to refer to the curriculum for basic specialist training in OB and Gynae, as the MRCPI in OB and Gynae is based on this curriculum, and it serves as a blueprint for the exam. So everything has been mentioned there on the website, and if you will look at that one, frankly speaking, they can ask you about any condition in obstetrics and gynecology. So then the objective structured clinical examination consists of 7 active stations, each of 10 minutes duration, including interactive stations. There is a 2-minute rest period in between each station. The examination tests factual knowledge and understanding, problem-solving skills, diagnosis, investigation, treatment, clinical skills, and communication skills. The clinical examination consists of the presentation and discussion of one long clinical case in either obstetrics or gynecology. Each candidate is allowed 20 minutes to examine a patient before discussing it with 2 examiners for a further 20 minutes. So now they have changed this thing. Now when you will be taking history from the patient, clinical examiner will be sitting with you. So Irish people, I mean the people from college, they are already very particular about history taking skills, and then how do you examine patient and how do you proceed through the this case. And now it will become more critical because the examiner is going to see how do you talk to the patient, how you address them, and are you asking appropriate questions, and are you answering questions of the patient, and do you know about the management of the cases. So you should not be stressed out, okay? And since all of you are practicing doctors and you are already taking histories, writing down the investigations, writing down your management plans, so it should not be hard, because that's all you have been doing, okay? So don't be nervous, just go there, take appropriate history, and then proceed. So a pass in the OSCE clinical examination is mandatory, and it is achieved by satisfying the following conditions. Obtain the minimum pass marks for skills which have been preset. Obtain the overall minimum pass marks, which is determined by the board after a thorough data analysis which takes into account both the difficulty of the examination stations and the overall performance of the candidates taking the exam. So pass a minimum number of stations required. Usually they expect you to pass 5 stations out of 7. Then pass the clinical long case. And then it is important to remember non-adherence to the WHO hand hygiene standards. It will result in an automatic fail in the clinical examination. So what you have to do when you will go to the patient, don't shake hands with them, and don't touch your hair, don't touch any belongings of the patient. And if you need to examine this patient, then usually you have to wash your hands, because now the clinical examiner will be sitting there, so you should do that. Usually the patient will be in a large room, so either you can find a sink on the bedside, so just go there, wash your hands, clean them, and then rub them together to show them, because in November it's going to be very cold, though the rooms will be air conditioned, but you have to show the examiner that you are caring for the patient. And then you should introduce yourself, like when you will go for the history, you will introduce yourself. So you will sit there, you will write down the history, and then you will ask her that can I examine you please. So, and intimate examination is not allowed. So after that you have washed your hands, there will be tissue papers, just clean your hands and then rub them together so that they will be warm. and then stand on the right side of the patient and start examination. And we will talk about it, that how you should proceed, how you should examine her. So just don't touch your hair or anything, okay? So usually what happens, 3 stations are based on gynecology, 3 are based on obstetrics, and 1 station will involve communication with a role player, and usually you have 2 rest stations. So 1 station will test your clinical skills and you will be asked to interpret results, reports, identify an instrument, its uses, and describe a surgical procedure, its complications, how to obtain a valid consent or clinical governance concepts. They can basically test anything here. They can ask you about liver ward prioritization. They can show you an audit report, but they will give you 10 minutes before that station. And if they want you to comment on some protocol, like patient information leaflet, you have to do critical appraisal of medical literature, or prioritization of the OR list, or prioritization of the labor ward list. So they will give you 10 minutes. So you will make your plan, and then you will go to the examiner, and then she will ask you that, have you seen this document? What is this? What are they asking you? Okay, so tell me how you will manage this thing. So then in a stepwise manner they will ask you, and you just don't have to comment that I will do this in this order. You have to justify your management. That is important. So then the stations are going to be from all basic modules for the OSCE. So you don't have to worry about that. You should just know the basic facts, because here the time is important. You will have like 10 minutes, okay? So 2 minutes time to read the question, and then 10 minutes to talk with the examiner and answer their questions. So that's all you need to do. And we are going to practice with several stations. And then I want to, like here I've given you a sample circuit. Like the first question, they are asking you about a lady who is 35-year-old, Gebra 3 para 2 with 26 weeks pregnancy with suspected IUGR, and she has been referred to your clinic. So how will you diagnose it? How it will change your management? How will you will plan her delivery? Okay. These are the points. Then another station can be like this, that obstetric cholestasis, they are asking you a question on that, mitral stenosis, laparoscopic procedures, endometrial polyps, role pair with secondary infertility. Then they can ask you to interpret lab results, radiology reports, instruments, and you will have to describe a procedure. So what happens on the day of exam is that 2 circuits are there, one in the morning, one in the afternoon. So and for each circuit 2 or 3 groups are invited. So you need to reach the examination center on time, and they will ask you to come like 30 minutes before starting your circuit. So take your identification documents, take the email the college has sent you, and highlight the station number on that, because that is the number from where you are going to start your examination. So you will go to the college building or your exam venue. They will register you, identify you, they will check your documents, and then they will give you like 10 stickers. So they will not give you any notepad or anything. Just take those stickers with you. They are very important because they are used to identify you, and on each station the examiner will have 1 mark sheet for each candidate. So you will give your first sticker to the first station, and then 7 stickers will be given on 7 stations. They will put those stickers on the examination, on the mark sheet, so that they can judge you, they can assess your performance. Once you will finish these 7 stations, and since there are 2 rest stations, so it will take like 2 hours. After that, they will tell you in advance on the day of the examination that where are you going for your long case. So see, basically if you are taking in Dublin, they have got 3 main hospitals, Rotunda, National, and Kumbe. So you will go there, and they will then see that who else is with you. so that you can go to that new venue with one of your friends or the other participants. There again they will identify you, so they will ask you to give one sticker, they will put it somewhere on some sheet. Then you will have to wait for some time, and then they will take you to the room of the patient. They will give you two A4 sheets and a pencil, so you are not allowed to carry any of these things with you. But I would suggest that you should take a measuring tape, take a torch, a hammer, and a stethoscope. You can take them with you. So BP operators, you should not be carrying so many things with you. So you will go there, and now the examiner will be sitting there. So long case, this is the most important part of your exam, as it forms the basis of your success in the exam. If God forbid you fail it, then you will fail OSCE also. So after finishing 7 cases, the candidate is required to go to the assigned hospital, and they have given you sheets. You can take some of the things with you. And now, since they have changed it from November, so what will happen? The clinical case is now fully observed, and the clinical case will now be 25 minutes in total. Previously, it used to be 40 minutes. Now 25 minutes in total by the bedside. So the revised format allows for a much greater level of communication between candidates, the patients and examiners, and face-to-face examining time has been increased. So there is no change to the OSCE component. So you will have like before 7 stations. You are required to pass 5 stations out of 7, and you are going to be fine. And so in 25 minutes you need to take appropriate history. Very important to take a detailed history in limited time. So how you can do this? Practice following a suitable template to avoid missing any vital information. Then you need to perform examination with consent of the patient. No intimate examination is allowed. You have to start with general physical examination. So look at the face of the patient. Is she comfortable? Is she fine? Then with her permission you should look into her eyes sclera, that she is not anemic or she doesn't have jaundice. Examine her oral cavity, that she doesn't have any ulcers, no pallor, no cyanosis, nothing. And then you can listen to the heart and portray that you are listening to the this respiratory sounds also. And then with her permission you can expose her abdomen, look at the fundal height, and usually the examiner will tell you that how do you do these pollic grafts. Can you tell me what is presentation of the baby, and then can you tell me what is the fundal level. So take this measuring tape with you and measure that, and then tell the examiner. So they will see that you are measuring from fundus to pubis or pubis to fundus. So during the OSCE I will also ask you that how you are going to do that. After that they will ask you certain questions. Usually they will ask you like 10 to 12 questions, and they can ask you the questions on the same case or some different topics. After that the examiner will ask you to leave, so you must say thank you and leave the room. Okay. So usually the candidates who fail the OSCE or the clinical examination, they must retake this component of the exam, and candidates are usually notified of their result by email only. In no circumstances the result is given by telephone. So usually they take a 4-week time. So the issue here is that you have to do very well. You should not be confused, and you should try to do your best. Why? Because it is very hard to get a chance on the OSCE. Any questions so far? Any issue? And as we proceed, if you have any question, please just ask it, because I don't want you to go to the exam with any confusion or any misconception. So you should be crystal clear, because if you know the method and you know that what they expect from you, then things will become easier for you. Any question, any problem, any one of you? 25 minutes, you know. Before it used to be 40 minutes. For 20 minutes, you were allowed to take history and do examination. But now, like they are telling you that they will give you 25 minutes. but you have to take a good history. You are not allowed to carry any watches, any mobile phones, any devices with you. So that's why I want you all to be perfect in your history taking skills. And it may seem childish, but like we are going to talk about the history, and then tomorrow I want all of you to say the same points when we are taking the history. Any other question you have? I think Viva will be for 5 or 10 minutes. But trust me, even these 10 minutes, they will seem very long because they will ask you questions. You should not be confused, okay? Just they will ask you about the basic things, not complicated, because they are not trying to fail you. Basically, they want to see that how do you take a history, which is very important, and they are very particular. So just follow these points, and you should be able to take a good history in 8 to 10 minutes. And examination will take like 2 or 3 minutes. Then it will leave 10 minutes for OSCE. So for the questions, and these the patients, they are very smart, and they have been directed to tell you some, give you certain information. They will tell you that what has been done so far for them. Okay, so you need to ask that also, because the clinical case, it will not end when you have done this examination. You go introduce yourself, take history, do this targeted examination, and ask her that what has been done so far. Like if she is preterm, always ask her, have you received magnesium sulfate? Have you received antenatal? Have you received steroids? Or you can ask her, did they give you something for improving respiration of the baby? She will say yes or no, they have given. And did you receive antibiotics? She will tell you that I have been given some drugs, and they will give you the name of the drug also. So then you have to summarize the whole thing. You will say, you will read for the examiner. Here we have got this 34-year-old, Gravida 3, Para 2, with this many weeks of gestation. She was admitted from ER on that day because she had 1, 2, 3 these problems, and during examination she was found to have these positive findings, and this much has been done so far. So like a paragraph, okay? So you have to be quick, but you should not be nervous, and you should not miss any points. Just take an appropriate history, because it will leave a good impression on the examiner. And 70% of the times the cases are of obstetrics, and 30% and the cases are on gynae. And you can find anything. And then regarding the viva, the examiner is free to ask you any questions. Like I will give you one example. 2 years ago, they brought long case of someone who had a placenta previa, previous 3 cesarean sections, and she had history of having an ectopic pregnancy. So this lady was at 34 weeks. So the candidate who was examining this lady, she thought that her viva will be on preterm labor or placenta previa or cesarean section, but they started asking her questions about ectopic pregnancy. So this girl was very upset, and she argued with them that when she has got so many problems, so why you are not taking Viva on these issues? Why you are remembering an ectopic pregnancy which she had like 10 years ago? The examiner said that it's my right, I can ask you about anything. So when you are taking history, don't just keep your options open, okay? Examiner can ask you about anything. You are just going to present your case, and then you will wait for the examiner, and he will start asking. Mostly they will ask you about the same case, but sometimes if they have directions that they need to ask about different things, they can ask you. And don't think that all of the cases are going to be very hard, these long cases, because once they gave a case of transfer slide. So she was at 37 weeks. She was already in the hospital. So as you know that we just have to wait for this patient. We are not going to induce her, and she declined this any intervention, and we had to admit her because Walaikum Salam. Yeah. How are you? 23 minutes ago. We started at, yeah, 8 o'clock. Yes. No, it was not 3 hours ago. Uh, 8 o'clock we started. Anyhow, if you have missed, no, 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 yeah, yeah, yeah. But please don't worry. Yeah, it is recorded. Please don't be upset. It is recorded, so you will be able to listen to all the conversation we have done in the last 25 minutes. Okay, don't be upset. So you will be able to listen to and you will be able to read everything we have done so far. Okay, so yeah, so okay, okay. So the history taking. Um, will any one of you like to talk about history taking? How do we take history in obstetrics? Yeah, anyone who wants to say anything, most welcome. Yeah, please go ahead. Yeah, okay, okay, mhm, yeah, Yes, thank you very much. That was a good pattern for taking history in obstetrics. So you have mentioned all the points, so everyone should have these points on their fingertips. So I will just give you a brief review, and like if they give you a case in obstetrics, patient identification is very important. That is the basic thing. Okay, so after that, what you have to do, you will start with open-ended questions like this. Can you please tell me about pain in your tummy? This is an open-ended question because like Dr. Fariha said, if a patient has a pain in her tummy, then you need to ask like 8 to 10 relevant questions. So where is the pain, how it started, is it confined to this place, is it referring somewhere else, how does it go away, and what makes your pain worse, are you having any associated symptoms like vomiting or pain on urination, so are you able to sleep like this. So you will have to ask many questions. Okay, so you should ask just a one question, open ended question. So can you tell me about pain in your tummy? So she will start telling you because she has been briefed that morning that if someone asks you about the pain, we expect you to say something like that. So they will also have a sheet in their hand and they will tell you what happened, how it happened, all WH questions. Okay. So then once she stops, and don't intercept. Okay, don't interrupt at all. So let her say whatever she wants to say and then keep writing that. You can practice write in your shorthand, or you can write that because time is very limited and the examiner is not going to read that one. So you are going to read for him. So then after that you should ask a few closed-ended questions. Closed-ended questions are those where the patient will have to answer by just saying yes or no. So once you take this open and ask these open-ended questions, and if there are some gaps in the history, then you will fill them by asking closed-ended questions. So for instance, if she had this placenta previa and she had pain, so you should ask her, so you are still bleeding heavily? She will say something. Or if she has like heavy menstrual bleeding, she will say yes or no. Patient identification, name. You are going to introduce yourself. I'm Dr. Fariha. I'm here for my exam today, and can I take a history from you? She will say yes. Name, or you can ask her, how will you like me to address you? Date of birth. Don't say how old are you. What is your date of birth? Where do you live? What do you do for living? So what is your educational background? Did you finish college? Did you finish high school? So how much money do you make? And then which is the nearest closest health facility? Where do you go generally for health checkups? Then you need to ask that are you generally fit and well, or do you go to GP? She will say yes, where? And then she will tell you if she has any medical issue or something. Then gravidity, parity. Okay, at the same time you can ask her planned pregnancy, unplanned, spontaneous, or assisted, or you can take this in the obstetric history also. Okay, so you should ask her how many times you have conceived, how many children you have delivered, how many children are with you, any history of miscarriages. So then assess her period of gestation. When was the first day of your last menstrual period? So you can calculate expected date of delivery, and these patients, they will also know their EDD, so you can say that your estimated date of delivery is this and this. Okay. So where you were booked, and did you receive, are your immunizations up to date? She knows and she will tell you. Then ask her that what happened. So chief complaint you will register in chronological order. Ask the duration of the complaints, and sometimes the patient will report herself to ER or to the clinics, or sometimes you will find a referred case because all these hospitals are tertiary care hospitals, so referral cases are also there. So what is the basic complaint now? Pain, bleeding, leaking, or whatever it is. Then you will take history of presenting complaint or history of present illness. Ask her to elaborate symptoms. Like we said that if the pain is the main complaint, so then you will ask, can you tell me what happened? Can you tell me about your pain? And sometimes they will know the etiology. Like she will tell you that I'm bleeding because but I was ready for it because they told me 2 weeks ago that my placenta is lying low, so I can have bleeding. Any complications like she went into preterm labor. So how is the baby moving? Okay. Any complications, diabetes, any high blood pressure during this pregnancy. So then again you should ask about the history of current pregnancy. In the first trimester, spontaneous conception, artificial, planned or unplanned. Then pregnancy was detected by which test? Uh, then pregnancy was confirmed by urine or serum pregnancy test. Then where was pregnancy confirmed? In the GP practice, in the early pregnancy assessment unit. So has she been coming regularly for the antenatal visits? Any history of excessive vomiting, fever with rash, any exposure to radiation, any bleeding per vagina, any history of any infections, any problems with the waterworks, any discharge, is she on any medicines? And then if she's in the second trimester, ask her how did you feel in the first 3 months? She will say, oh, I was fine except this occasional nausea and vomiting. Or she will, if she had this hyperemesis, she will definitely tell you about that. So she's in the second trimester. Ask her that how many visits you have done, how much weight you have gained, what investigations they did on you. So you will ask her, did they check your blood sugar level? Have they been recording your BP? Any other problems? Any history of swelling of feet? Then how is the baby moving? When did you feel the first fetal movements? Then any history of bleeding? Are you taking any medicines or any vitamins? Because you will have to tell about all positives and all negatives, what she has been doing and what she has not been doing. If she's in the third trimester, ask her how were the first 6 months of your pregnancy. Anything of concern, anything which bothered you, any hospital admissions, any pain, any discharge, any bleeding. So then she's in the third trimester, that were you regular in your visits? How much weight you have gained? Any history of diabetes in pregnancy? Any history of elevated sugar in pregnancy? Any history of high BP? Any history of bleeding? Any history of pain? Any history of preterm labor? Did you have any itching? And have you been on any medicine? Then take her menstrual history. When was the menarche? Were the cycles regular, frequency, days of flow, volume, any clots, have you ever experienced bleeding in between periods? When was the last menstruation? Any abnormality? Then at the same time ask about contraception, and that have you been taking regular contraception? Have you been taking anything for birth control? Okay, so is it working for you? Okay, that's fine. History of smears is very important. Are they up to date? Any abnormality detected before? What action was taken? Then ask about marital history. This is an important parameter of well-being. Ask her that you can ask about the husband, that tell me about your husband. What does he do for living? For how long you have been married? Are you cousins? Any history of infertility? Any history? And if she says yes, then you will have to ask that, do you have any children before? Because of course you will know, but again you need to ask her that, have you ever conceived or no? Or sometimes they will give you a case of secondary infertility also. Okay, so that's why you will ask her. But this question will become irrelevant if your patient has 3 or 4 babies and she is pregnant again. Okay, so you can modify your history according to your case. Then previous OB history, that conception, after how many years of marriage, what type of conception, spontaneous, okay, or it was assisted, planned, unplanned, any history of bleeding during pregnancy, any history of high blood pressure, baby was of normal weight or baby was small, any history of elevated blood sugar level. How was, tell me about your labor. So it started on its own or they had to do something to help you, or did they give you any drugs, what they did? And tell me, what was the duration of your labor? Was it long? Was it short? Was it ultra short? So what was the type of delivery? Normal, assisted or lower segment C-section. So did they give a cut down below? Then any history of bleeding? Did you receive any blood? So ask about the baby. Live birth, stillbirth. What was the weight? Was there any anomaly? Was there any abnormality? Was anything wrong with the baby? Was that baby admitted to the baby unit? Was the baby seen by the baby doctor? Because maybe they will give you a case of high drops also. Actually, they asked about a case of RH isoimmunization in 2017. So, did you breastfeed that baby? For how long? And it was okay with you? Then, how is the baby doing now? So, how was the period after birth? How was your after birth? Placenta is after birth. Any problem? Any issues? Okay, maybe she has a history of PPH in the previous pregnancy. Okay, then did they put in case of cesarean section? You should ask that when did they remove this tube from the bladder? Then after that, her blood group is very important, and these patients will be knowing about that. So please tell me, what is your blood group? If she says that it is negative, then you need to ask her, did you receive anti-D? So she will tell you. Okay. And then after that, what did you use for spacing between children? So is it working? Did it work for you? Was that a good experience? Okay. Any complications on that drug? Nothing. If he had a previous cesarean section, you need to ask her that it was a planned one or unplanned because you had some emergency. Labor pains, any blood transfusion, did they remove any suture? So about the catheter removal, that they took out this tube from the bladder on time. And did you develop any fever? Did you develop any infection? So baby was kept in the baby unit. So did you start this breastfeeding? If this is post CS in this pregnancy, or they can bring in any sort of patient, but you should not be confused. That is the basic trick. Okay. So if she has undergone this cesarean section, then you need to ask her how she's doing. Is she mobile? Is she drinking, eating? Has she started breastfeeding? In case of stillbirth, ask her when did it occur? After how many weeks of delivery? How many weeks of pregnancy? And what was the weight of baby? And then ask about the labor, that it started on its own, or they started it for you. And what was the reason for the stillbirth? Was the baby born before he was supposed to take birth? Did he have any problem? Anything wrong with the baby? Was the baby small? Any history of cord prolapse? Did the cord come out? And did you have high blood pressure, or did you have this high blood sugar during pregnancy? If she has a history of miscarriage, you should ask her what was the cause. Before it was illegal to offer this miscarriage or termination of pregnancy, but now last year it was approved, but still the college has not given any ruling, so you are going to stick to the old practice that it is not allowed unless there is threat to the life of the mother, and two practitioners they have approved that she can go for termination of pregnancy. If you suffered a miscarriage, ask her, was that spontaneous or planned? Sometimes they will go overseas to get it done. So at how many weeks? So baby, all products they came out on their own, on did they have to remove them? Then what was any removal of the products done? What was, if termination of pregnancy was offered, where did she experience any complications, and when was it? Because the duration is very important. Then go to her past history. History of any surgeries, history of any operation, because operation is not medical jargon, everyone understands that. History of any operation. So what was done? When was, did you receive any blood transfusion? Do you have any medical condition? Are you generally fit and well? Then any history of blood transfusion, any history of this, if she's depends that to which area she belongs. If she's immunosuppressed, ask her any history of TB, any history of genital infections they all understand. Any problem in the heart, any diabetes, any other problems, you will ask, do you suffer from any other condition? Please tell me a bit more about that. And then who is caring for you? Okay, that's how you're going to ask. So then, very important patient safety issue, please never forget it in your practice and also in your exam. Tell me about this. Are you allergic to any substance, any medicine? If she says yes, then ask her, please tell me what happens when you take it. So you will get just rashes or what? If you will say that only rashes and for short duration and they went away without any intervention, then you should know that this is minimal, so she is not allergic to that substance. But if he tells you that I took that med and then they had to rush me to the hospital, and they had to give me oxygen and they gave me many shots in the muscles, then of course you need to care for that. And you will say that she had anaphylaxis, so you are allergic to this drug. Okay, I will write that in bold letters, or I will enter that in red ink in your record. Okay, so that's how you're going to take a history of allergies. Then you should say, I need to ask some personal questions. I hope you don't mind them. So, are you on any drugs, any medicines for any medical condition, or do you take drugs? Because this problem of drugs is very common. Then, do you smoke? Ever, ever thought of quitting? So, do you think you need help for it? Okay, I will give you number of the service and they can help you in quitting. Then ask about the psychiatric disorders. How has been your mood in the last 4 weeks? 4 weeks. Previously, we used to ask them, how has been your mood in the last 3 months? Now you will say, how has been your mood in the last 4 weeks? Then you should ask her, are you having as much fun as in the last month as before, or is there something which is bothering you? Anything that comes to your mind is okay, but you have to ask those questions. And if she says yes, then you should say that we need to further invest for we need to ask you further questions. Then, do you sleep well? Is there anything which is disturbing your sleep? So, any change in eating habits? Any change in the recent changes in the weight? What about your bowel? About your gut? Are you moving it daily? And what about your water works? And if she is addicted, you need to ask her that have you been registered anywhere? And have you ever received any help for it? If she says no, then you should say that, I don't want to be judgmental. This is your personal issue, but I would suggest that taking drugs can harm you in several ways and it can harm your babies also. And there are good services available and they will keep you maintain your confidentiality and they can help you at the same time. So diet, are you still your appetite is good, or is there any change? Because if your patient is depressed or she has some hepatic disorder something, she will say that I don't feel hungry anymore. Okay, so in the patient is there inside, so you can mention on the chart that food intake is normal. Ask about the family history. Family history is very important. It will also give you some clues about the risk profile of this patient, because maybe you will ask her and she will tell you that there is a family history of blood clots on leg veins or history of cancers. Both of these are very important conditions. So history of diabetes, high blood pressure, multiple births, history of having any babies which were not normal in their appearance or in their function, any history of infections in the family, any bleeding disorders. Then how you will summarize the whole thing. You will give the patient identifies this many years old and she is so many weeks of at how many weeks of pregnancy. She came with complaint of dash for how many days, how many weeks, or she was referred as a case of, you will mention the diagnosis from where she come from where she came, and that does she have any comorbidities. With no, if it is negative you will say no morbidities, and she was admitted for evaluation of or workup of or for safe confinement. Anything can be there. Okay, so that's how you're going to summarize the whole thing. So any question, any point, any observation? Okay, so okay, that's great. So what will you like to do in the examination if you have an obstetric case? So what will you like to see? Because yeah, uh, yeah, just 1 second. You know, history taking is more important, because if you have mentioned all of these points, and then they will have a blueprint or a rubric. So even if you forget any points, don't bother, because they will have a mark sheet on which they must have written detailed candidate has taken a detailed history of this condition, has asked these questions. So 5 questions are there and you have asked like 3 questions, so they are going to check the boxes that this candidate has taken an appropriate history and she has asked about 5 following points. Then they will go to the next point, past history. Yeah, they have asked about that and they have mentioned these points. So after that they will go to the next segment of the history. So it's not essential to remember each and every question, but you should try to cover as many points as you can. And any exam you are taking, this history taking is the basic skill. And the problem is that people, they keep practicing with the more complicated problems, but they don't focus on simple issues. So keep things very simple. Basic history, basic examination. Okay guys, please tell us how you will do an obstetric examination.
The static examination that we will introduce ourselves to the patient, take consent from the patient for examination, and we will have a general look from head to toe, take the BMI, blood pressure, pulse, respiratory rate, and if indicated, oxygen saturation and capillary refill. Apart from the general physical, if we go to obstetric, then we will come to the only pregnancy probable examination. If needed general physical, then we will do the chest examination and the cardiovascular examination. But if not needed, then obstetric examination, we will check the first of all we will do inspection.
Yeah.
And in inspection, we will see if there are any masses, any prominent vessels, any hernias, any like we will describe if we see any abnormality on examination. And in pregnancy, like we can say that there is a bulge, but this is basically pregnancy and it is how many weeks. And then we can do the superficial palpation and we will ask the patient first that she has any pain anywhere, and we will not start from the point where she has the pain. We will start from the other side. Then we can do superficial palpation of all the quadrants, and we will then do the deep palpation. And basically in obstetrics, we are doing like Newton's maneuvers. We will check what is the lie of the baby and the fundus, and then the both the sides, lateral and right and the left lateral, and then we will check the presentation. So there are 2 types of methods for presentation. One is the product grip, that is painful, so usually not done. But then we are checking from both ends, and both of our fingers we are putting on the suprapubic area, and then we are checking the presentation and checking whether the head is engaged or not. And when we are checking the fundal height, we will use the measuring tape and we will put the zero at the pubic surface, is the fixed point, and then we will measure the fundal height. And then we will take the fetal heart sound, and then we will ask the patient to, we will keep our face towards the patient, and we will keep the, if we are taking from the stethoscope, benign stethoscope, we will check where is the prominent, like where is the chest of the baby. And then we will put the canard stethoscope on that point, and we will take at least 1 minute fetal heartbeat. And then if we need further examination, then we can do the venous thrombosis assessment, we can check the edema and all these things.
Yeah. So excellent. You need to do all of these things. And now when they have reduced the duration of Viva will be very short, like maybe 5 minutes, maybe 8 minutes. Okay. So since this is a long case, so you will take a detailed history and you will do the examination. Dr. Priya has mentioned all the points. I will just briefly go over all of these again. Prior to examination, tell the patient why you need to see her and you will take verbal informed consent. Then stand on the right side of the patient, and usually the light is good, and then you have to tell her that since there is no one else, so we are not putting the screens. Okay. So, and you don't have to undress the patient, only if you are doing this fundal examination, then you need to do that. So in the general examination, you should say that she is lying comfortably at rest in the bed, she is conscious, and she is oriented to put cross 3, time, place, and person. of average build, moderate build, or BMI is very high, it is poor, average, or sometimes the patient, you can ask the patient also, what is your BMI? Because if they have been following up regularly, they will tell you about that. Even if they have been admitted at the time of admission also, they are calculating their BMI. So then look for pallor, jaundice, cyanosis, clubbing. Just compare her arm, her, this um, palm with your palm, okay? That there is no pallor, nothing, no edema. This is the general physical examination, okay? And usually, only you will palpate in the neck, that no lymph nodes are palpable. Then vital signs, you will say that I've just taken her pulse and respiratory rate, this is this much, and temperature seems fine because you won't have a thermometer. And you will not find any patient charts because everything is electronic, so you will not find anything. But you can ask the patient, when did they check your BP? She will tell you that they took it like 2 hours ago. So do you remember the reading? She can tell you because she has been instructed to give you this information only once you will ask her. Then you have to see what is the facial appearance. Maybe has edema, is any hirsutism, when she seems hydrated or not. And you know because actually you cannot ask all of these questions. No sign of malnutrition. Sometimes anemic patient will be there who has this heavy menstrual bleeding and she has come for surgical procedure. So just put your stethoscope on the cardiac area and listen to that for just 10-15 seconds. So then you will say that normal heart rate and rhythm, S1 S2 audible, no additional sounds. Respiration seems fine, and you don't have to do percussion or anything. If patient has respiratory infections, then you need to do all of these things. Otherwise you will just say that sounds are normal, no additional sounds. If you have done percussion, you will say clear to percussion, and if there is any tenderness, anything, you will have to mention that. Breast examination, you are not allowed this on the exam. You will say that breast this seems symmetrical, and ask her to swallow her saliva. Is there any mass? No, there is no mass. And any problem with gait, spine? Nothing. Then on the abdominal examination, there are certain prerequisites. Ask about that. Can I see your tummy? Okay, it is not going to hurt you. So then keep the patient under the sheet, okay, covered. Then you should say that ideally I should be examining you in the presence of a chaperone, but this is exam and I'm seeing you in front of the examiner. Is it okay? Then you don't have to expose her, okay? Just look at the tummy. What is the lie of the baby? Is there any distension? There is abdomen seems distended because she is having a pregnancy. She is pregnant right now and she is at how many weeks? Then is there any pain? Is there any scar? Important because maybe the patient has not told you that she underwent a cesarean section in the last pregnancy and now you have seen this scar. And are there any visible pulsations, anything abnormal? Is the abdomen symmetrical? Then with her permission you can do this. Fundal height, this almost everyone will take in the examination. So gestation age is how many weeks in this. And then the legs should be elevated, like in the semi-flexed position. Ask her to elevate her knees, raise your knees, okay, like that. And then you have to see that baby, it is central, the baby is fine, can you feel the movement? And it's in physiofundal height, like you said, that you will measure it from the fixed point from the pubic symphysis to the level of the fundus. Then inside of the tape should be toward yourself, okay, so that you will eliminate the, because we are going to give the height in centimeters, okay. So examiner will be looking at you, so inches should be towards your side, okay, so he will know that you are being impartial. So you are not making up things. Inches towards your side, centimeters towards the lower side, towards the side of the tummy. So then you will say that how many centimeters it is. Then fundal grip, or you can do this Leopold grips, and like the patient's legs should be semi-flexed. Palpate gently with fingers, not fingertips. You have to put the fingers. Little gentle pressure. Move one hand at a time for palpation. Move hands from lateral to midline. Come from the sides to the center. Where is the head of the baby? Okay. Is it in the lower part? Okay. If it is breech, then you will feel the head above. So then you can say that This form broad, irregular, and not palatable mass. No parts palpable, then you will say transverse lie. Then you will go for the lateral grapes. So second dipole grip, umbilical grip. One hand for support to make it steady and another hand for palpation. Don't poke fingertips. Move one hand at a time. So you're going to notice the tone of uterus, amount of liquor. Where is the back of the baby? Is it smooth and curvy? And is there any problem? Then limbs. Sometimes you can feel, sometimes you cannot. With the liquor, you cannot estimate, but you will say that things are fine here. Then go for the first pelvic grip. It can be like pollic or it can be Leopold grip. First put the inner side of your hand on upper border of the symphysis pubis. Palpate the fetal head between thumb and fingers, okay? And don't press very hard. Look for head is ballotment or ballatable or not. Is transverse lie, and then this poly grip will be, you will not feel anything, okay? Then go for the second pelvic grip or fourth newport grip. You don't have to mention the number. So examiner's face should be towards the feet of the patient. Palpate the lower abdomen from lateral to medial side. Check for whether the examiner's hands are converging or not. Then what is the level of the sinciput or occiput of the head? Depends that what is the condition. Then if this patient has a previous scar, then you should palpate the skin. Is there any tenderness? Is there anything? Is there any abnormality? Then you will have to auscultate. Fetal heart sounds. It tells about whether the fetus is alive or not, and fetal heart sound is best audible from the left scapular region of the baby. So just if you can locate, fine. Otherwise, if the mostly the babies are in cephalic presentation, and you can feel their heart sound around umbilicus on the right or left. Okay. So in twin pregnancy, two different heart sounds will be there. But if you don't listen to hear any audible sounds, then you should clearly say that she gives that the history that the baby is moving well, but I cannot find both hearts. So you have to be honest. Okay, no one is going to say anything to you. So then estimated fundal height, that how much is this one. You are not going to give them the weight of the baby or anything. Then you will say that so this patient is fine, gestation age is this much, no comorbidities, single fetus and seems with this which is lying in this presentation, and things are fine. I have felt the fetal movement and like that. So then the intimate examination, you are not allowed to do that, okay? So you don't have to do that one. So that's how you will perform the examination, and you will tell your examiner that I have seen this patient and she has these conditions or she seems fine right now. Okay, so that's how you will conclude your examination also, and then they will ask you about other points. Okay, thank you very much. Now someone else should volunteer how you will take gynae history. You all have to practice, otherwise there are so many books and you can just sit at home and read. Okay, so don't hesitate. You should volunteer, because in this exam they are going to see that how do you communicate, and this is an exam of your skill as well as attitude. So, and this is your chance to speak, okay, because you are practicing here. So anyone else would like to talk about gynae history taking? Hello. Yes, welcome. Hello, yeah, I can hear you. Welcome.
Okay, I'm Zaina. Yeah.
Welcome,
Yeah,
Dr.
I'll
Saina.
start with the gynae history.
Yeah, most welcome. Please start.
So first, yeah, gynae history. First, I would like to ask the patient. First, introduce myself and confirm the patient's name and age, and start with the open questions. Can you tell me more about your concerns and your expectations in this consultation? So, why she come to the clinic and does she have any problem? Then the patient starts with her complaints. Then, as usual, does she have any bleeding or maybe a pain abdomen, bleeding, and infection? Just go in detail about her complaints that she's telling. Okay, how was the pain? Is it a radiating pain or localized towards one side. Does she have any gaining history of passing clots? And so based on the history, I will carry on with the main complaints. And then does it affect her quality of life, the physical, sexual, the social quality of life, these problems does it affect? So this is a history of present illness. And after that, after I ask the history of present illness, then I would like to ask the close questions. Can I ask you a few questions that will help me to come to a diagnosis and plan a best management for you? Is that okay? Start with the same pattern as you thought. Are you allergic to any medications? Do you have any medical conditions for which you've been discriminated before? Are you on any long-term medications? Then come to the obstetric history. Were you pregnant before was it spontaneous, planned or unplanned? The mode of the delivery, was there any complications in her previous pregnancies? And does she plan to have children again fertility? Then after that, the main thing is the gynecological history. Coming to the gynecological history, her LMP. Then anyway, the main history in the gynae, she has taken it before. So I would just ask her the last menstrual period, whether again whether she had any intermenstrual or post-coital bleed. Then up to date with her smears and her contraception. So since I've highlighted earlier, so in short, I would like to go through this. And then after gynae history, the other histories, like what you have said, go ahead with the social histories, whom does she stay with, what does she do for her living, how is the support system at home, and is there any family significant history like cancer? Gynae is very important for us. Any family history of fibroid or these things, I would like to ask to the patient, the specific things related to gynae in this case. And after that, about her habits, smoking, alcohol, and drugs. And that's all. Then summarize with the history. So she is having such and such problems, such and such years, and what treatment, I forgot, sorry, what treatment has she been shown anywhere and what treatment she is on. That is very important, which I missed out in the history of present.
Yeah, that's very good.
And,
Yeah, please carry on. Yeah, that's fine. You will summarize the history and present that to the examiner. That's very good. So you have taken a good history, and like I'm telling you that to pass the long case, first of all you have to stay calm. Okay, there will be nothing unusual because in the exam you are going to find common conditions, even on the circuit and even in the long cases. You are going to find patients with common problems. Okay, so the point is that of course we are going to talk about the long cases in detail. We need to see that what sort of patients are usually admitted to the hospital. Like in the OB, abdominal pain, that is the most common complaint in the second and third trimester of pregnancy. So maybe you will get a patient with preterm labor. Actually, preterm labor, it accounts for like 60 to 70% of the hospital admissions. Then twin pregnancy. Then patient has any medical disorder. Most commonly, they will have diabetes, which can be IDDM or can be GDM or even type 2. And we have admitted her to control her blood sugar level. Then you can find someone with PET, someone for VBAC, someone for induction of labor. And if the patient is in the first trimester, um, she can have this hyperemesis gravidarum, but now she will be stable, that's why she is there on the exam. Or patient will give history of hyperemesis gravidarum. Then someone with a diagnosis of an ectopic pregnancy, but still it has not been confirmed. Or most likely she will be seen after surgery. They have done self-injectomy or something on her. So then going to the gynae side, pre-operative patients will be there. Then someone with a prolapse, advanced age, and she is there for vaginal hysterectomy. Because the minor cases like those who have missed miscarriage, IUCD removal, or missed IUCD, they are admitted on the same day as day surgical cases. So you are you're not going to find them, okay? Because they will not stay in the hospital; they will be discharged on the same day. So mostly in the surgical cases, those for abdominal hysterectomy, vaginal hysterectomy, large fibroid, then stress urinary incontinence. These patients are most commonly seen. So someone with with an ovarian mass, this sort of patients you are going to see, or some minor with dermoid cyst. So usually on the exam they will not bring any minor. Anyone who is 18 or above, they will be on the exam. So I mean to say that you are going to see the people with common conditions which you are seeing in your daily practice. Okay, so don't be upset. Any sort of patients they give you, just follow these templates of history. They will be available on your web page, and you should just learn the points by heart so that you will not miss anything, because the examiner is going to check the boxes and they will award you marks. So when you have to give a diagnosis, if you have reached some conclusion and you think that is the probable diagnosis, so then you should say it looks like a case of this one, this one, this one. Then they will ask you that are you sure about it? No, I need to do further testing. If you are sure, you will say that that's what it looks like, but I like to further confirm it. Gynae cases, they will be clear cut. Someone has endometriosis and she has been admitted for adialysis, so you can simply say that. So then it is up to the examiner that he will start questioning you on endometriosis and the scoring, or he will start asking you about the laparoscopic surgery. So you should be ready for that. And my advice would be, don't assume things. Don't make up things. Honesty is the best policy. Whatever the patient tells you, just write it down and present it to the examiner. Sometimes the cases will be quite, stable. They will make up things because they are going to follow the instructions the examiners have given them that morning. So whatever they tell you, you should just say those things. Don't add anything, don't eliminate any information, okay? And present that to the examiner and you are going to be good. So Dr. Zaida has mentioned all the points. Just a quick recap. Again, in the gynecology history taking, patient identification is very important. Start with open-ended questions like, can you please tell me about pain in your tummy? If there are any gaps, or even if there is no gap, but her history is there, so ask her a close-ended question just to tell the examiner that you know about the techniques of taking history. So you are still bleeding heavily. Then summarize history for the patients. I have understood that you have this complaint and you have been admitted, and this much has been done so far. She will say yes. Okay. Again, patient identification is very important. Name. How will you like me to address you? Of course, you will start it after introducing yourself. She will just give you a courteous smile. Okay. You don't have to tell her a lot. Just tell her, I'm Dr. Zahida. I'm here. I have an exam today, and I'm here. I'm supposed to take history from you. Can I proceed? And now it is more important because the examiner is going to sit there for 25 minutes. What is your date of birth? Are you married? And if depending upon her age, she can be perimenopausal, she can be postmenopausal. And do you have children, like births? And where do you hail from? Where do you live? And have you been? Did you attend college? She will tell you. What do you do for a living? Because if she will tell you about your occupation, then you will also get some idea about her background. So are you enjoying it, or do you like your job? So how are things? Are you financially okay? Do you need any assistance? Are married, unmarried, widow, divorced, separated, living alone? Are you in a relationship? She will tell you that what sort of relationship she is in. So please tell me, why are you here today? She will tell you that I have vaginal discharge with or without pruritus, or I had a bleeding, or I have some mass in the abdomen. And sometimes she will tell you that I have this horrible pain in my tummy or down below. Then sometimes she will tell you that I can feel a lump down below, something seems to be coming out of the area. Then if she has been referred, then you should say that she was referred from the peripheral hospital as a case of by Dr. So and so, and what were the findings. Then ask her for how long she has been having these complaints. You have to ask in a chronological order and write down. Actually, you have to write what is the chief complaint, what is the presenting complaint, then history of presenting illness. Patient was apparently normal. Patient was doing very well 6 months ago, and then she noticed this condition. That's how you can start. Elaborate the symptoms, duration, maintain chronological order. So does she have any risk factors in her history? Then any complications, any other associated complaints. She can tell you that I'm here for this surgery, but I'm very upset because I have this uncontrolled blood sugar level for the last 10 years, or I am hypertensive. My BP is often very high, so I'm scared but how it will behave during surgery. Any history of fever, any history of infection. Most commonly the patients, they will tell you about history of UTI. That is the most common infection in the OB/GYN population. Then ask history. If patient presents with discharge, then you should ask when it started, for how long you have been experiencing it. So usually how much fluid is there? Is it scanty? Is it moderate or excessive? What type of discharge it is? Is it thick? It is thin, frothy? What is the color? Have you ever noticed any pus in the pus? They can understand any pus in the discharge or your pad. So what color is the discharge? Is it white, greenish? What color it is, like white, greenish, gray, yellowish? So does it smell? So then are there any changes in the discharge, or it has always been like that? So have you ever noticed any blood? So please tell me, is it occurring at the time of your cycles, or it is not related to the cycle? Ask one question at a time, okay? Then do you have any itching? So it is associated with discharge, or even without discharge you have this itching. So she will tell you. Then history in patient with bleeding. Then what your questions you should ask? Bleeding per vaginum, then you should ask her. What is the pattern of bleeding? Like how were your cycles before? Were they regular and you used to have these bleeds just once a month? So are you having bleeds multiple times? How is the flow? Is it scanty? Or are you experiencing this bleeding several times a month? Then pattern of a menstrual cycle. Amount, quantity of flow, and associated with any passage of blood clots, any pain. What is the deal? When did this bleeding start? Is it usually it will be like this in each period, or this one is exceptional? Then what is the interval between two bleeds? Is it continuous, or is it coming and going? How did it start? On its own, or it was initiated after coitus, or did you have any bleeding in between periods? Any previous complaint of any chlamydia, gonorrhea, any other infection, any history of TB? Have you recently changed your pills? Are you using, these birth control pills? Are you wearing this device inside your womb? Because and when it was inserted, okay? Because in the start they can have spotting like this. If she has some mass in the abdomen, then you should ask, when did you notice it? Do you have any symptoms? It started suddenly, or it has been there for quite some time? For how long it has been there? Where did you first feel it? Then what was the size in the start? Has it grown now? So you are telling me that it has grown like by 4 inches in the last 1 month, okay? Things like that. So do you feel any, since this mass is big, so do you feel any pressure? So how is your appetite? For how long you have noticed this distended abdomen? So do you have any sense of bloating? Do you feel fullness after taking your meals? Is your appetite changed? Is there any change in your weight? Have you lost or you have gained? And what sort of pain you have? Please tell me about that. She will tell you that it is dull, I have a dragging sensation, then you should think about the masses. So any other problems it is causing? She will tell you that I can't breathe properly. Do you have any nausea, vomiting? Okay. Any history of swelling feet? She will tell you. If she has presented with pain, then you should say, how did it start? Sudden or gradual? where exactly did you feel the pain? So you will say, tell me more about the pain. So she will tell you when it started, how it started, and is it localized or it is radiating. If she doesn't mention, then in gynae case you need to ask her that did you have pain with your monthly cycle or before or after that. She will herself tell you that how this pain increases and how this pain decreases. And I will tell you that I had severe vomiting with this pain. I had fever also. So that's all you need to ask about the pain. If she tells you that there is something coming out of the vagina, then you should ask her for how long you have been feeling it. So it started suddenly, or it has been going on for quite some time. Then mass is always there, or just you will feel it when you are straining, like if you are trying to pass hard stool, only then you are feeling it. So if you cough or you pass stool or you are doing exercise, when does this becomes more bothersome? So does it reduce when you lie down? So that's all you need to know. So can you put this mask back with your fingers or you can't? Then how it is affecting you? She will tell you that since it is hanging between my legs, so it's very hard for me to continue walking and I cannot carry out activities of daily living. So that is about the mass. If she is having some discharge or maybe she has some other mass, something is there. So then if in cases of the prolapse, patient is not experiencing that something is protruding, but you have just felt it during examination, or she will tell you that my doctor examined me and she told me that there is a mass. So do you feel fullness or heaviness in the area down below, and does it come out of the of your this from the area down below, and when did it start, for how long it has been going on, can you put it back inside with your fingers or you can't? So do you have pain in the lower abdomen, in the lower back? So do you think, what about your water works? Is she passing the urine as she used to do it before, or she has any difficulty? If she says that no, I have difficulty, what sort of difficulty? She will say that I cannot start passing urine quickly. So do you have to strain? She will say yes. So how is the stream of urine? She will tell you that it is continuous, it is broken. So do you feel the need to pass more urine once you have finished passing it? She will say yes or no. So do you wet yourself if you cough? She will tell you. So then, or you lift weight. So you will know that she is having stress incontinence. So are you passing urine more frequently than you used to do before? So is it associated with any pitching, any itching, any pain in lower abdomen? She will tell you. Then you can think about UTI. So then you need to ask her that since you have this bulge down below, so do you have to push it with your finger to pass urine? She will say yes or no, because it will then tell you that she is having this prolapse and which is interfering with her micturition. So do you have any constipation? You are unable to move your bowels. Do you have cough? Do you have asthma? And for how long you have been experiencing it? So did you feel any mass in the tummy? You need to ask about the tumors. Then do you have any abnormal discharge from down below? So, or do you have any bleeding? How it has affected your life? How has it affected your sexual life? So she will tell you that she is not happy about the appearance of her genitalia, or she has pain on sex. So you need to mention all of these points. So I have noticed that sometimes the candidates, they will mention all positive findings that she has this problem 1, 2, 3, 4, and they will forget to mention the negative problems. So you have to tell about the positive things and the negative things also. That's how your history will be a complete history. Then ask about her bowel and bladder history, any problems before her water works, any mass, any history of having any bulge, any pressure symptoms like you are passing urine more frequently, or it is difficult for you to pass urine and you have to strain. Is there any change in the passage of stools or urine? Then if the patient has some uh, history of having some cancer, or she had some mass and she has been admitted for removal, then you need to ask her how often you are passing urine. Do you have pain on passing urine? Have you ever noticed blood in the urine? So have you ever passed urine without your knowledge, or have you ever passed urine when you didn't mean to pass it? So it means she's having incontinence. If she had any surgery, then you should ask her, like she had a vaginal hysterectomy, or she had, this second stage cesarean section, and now she has come with a fistula. Usually you will not find a patient like this, but you should ask her, do you think that your perineum is always wet? Your vulval area is always wet? So if she has fistula, she will say, yes, I can't seem to control it. Then any history of diarrhea, or is your gut more active now, or are you not unable to move your guts? Do you have pain on passing stool? Have you ever passed blood from the passage behind, from your back passage? Then ask about her menstrual history. When did you get your first period? So here also, you have to be smart. If she's a young woman of reproductive age group, then you need to ask her when was your first period. But if you are getting an older person, then you will not ask about the first period. You will ask about the last period. When did you have your last period? Okay, so she attained menopause at this age. Then ask her. Then you should tell her, I need to ask about your previous cycles. Were they regular? Irregular? What was the frequency? Do you remember how many days of flow? And then volume. History of passing any blood clots. History of pain with the periods. History of having a bleed between the periods. Or if she is postmenopausal, you should ask her that did you ever pass blood for your last period? She will tell you. So mention this last menstrual period. So ask about the smears. Are they up to date? So did you ever notice? Did you ever have any abnormality on smear? Okay. When it was detected? So what action was taken? Okay. So cervical screening program is essentially the same with a couple of differences. We will talk about them. It is just like the cervical screening program in the NHS. Ask about her marital history. How long you have been married? How many children you have? How old is the last baby? So, are you using any form of birth control? Is it working for you? Are you satisfied, or you feel like changing it? Then ask about her OB history. History of any infertility, nulliparity, history of miscarriage or ectopic, age at the time of this marriage, age at the time of first child, second child, third child, like that. History of breastfeeding, were the babies vaccinated, how are they doing now, any issues with the babies, like that. Then if she has like pelvic organ prolapse, or she is there for any surgery, you need to ask her that what were the modes of birth, babies were of average weight or what. And then if she has pelvic organ prolapse, then you should ask other relevant questions. Was the were the babies large? So what were the modes of delivery? Through the natural route, or they had to do a cesarean? Any history of miscarriages? Any history of abnormal labor? Any history of staying in the labor for longer periods of time? And what was the interval between pregnancies? Because this is assumed that multiple births they will precipitate this pelvic organ prolapse. History of any operative procedures, a history of any intervention. So labors were spontaneous, or they used some forceps, or they applied this vacuum. Then ask about the past history. Any history of surgery in general. Then any history of gynecological surgery, prolapse, like or some surgery was done on rectum. Any history of fibroids. Anything can be there. If it will be there, she will tell you. History of removal of the womb, or if she had some ectopic, any history of salpingectomy, or maybe she underwent this, she had opted for this BTL. So you need to ask about all of these things. Any history of infections. She will say infections like what? Like, you should say like tuberculosis, because it is becoming more common nowadays. Any history of infection in the womb or in the vagina. Any problem with the heart. Any history of diabetes, any other disorder, any problem. Or you can simply you can ask her, are you generally fit and well? Are you having any chronic condition? Are you having any medical issues? So if she says yes, then you need to ask who is caring for you. So is this under control or not? Then in the person history, again, very important patient safety issue. Are you allergic to any medicine? What is the extent of allergy? Just a rash or anaphylaxis? Like you will ask her, what happens when you take this drug? So she will say that I get this itching. So only itching or some other problems? She will tell you that no, it's only itching. Or sometimes you will say that once I had severe reaction and they had to rush me to the hospital. Then you will say it is anaphylaxis and tell her that I'm documenting it so that nobody will ever give you this medicine again. How is your sleep? Are you eating well? Any changes in the weight? Then again ask about the addictions. Do you smoke? Do you take alcohol? Do you take any drugs? If she says yes, then ask her, have you ever thought of quitting? And will you like to join any smoking cessation program? Okay, I will offer you information. If she says no, I don't have, no, that's fine with me, I don't want to change it, then tell her that quitting the smoking or drugs is good for everyone. If at any stage you feel like quitting, just let me know and I will refer you to the service and they will maintain your confidentiality. So what sort of diet you like? High fat, fast foods, or if she's obese. So if she needs to be referred to the dietitian, you should mention that one. Like if you have someone whose BMI is 40 or more, then you should say that I think I'm not criticizing you or I'm not being personal, but I think if we can shed a few pounds, it will be very helpful for your health. So do you mind if I refer you to the dietitian? She will make a plan with you and she can tell you about the suitable exercises and you can improve your health. Then again, if she has high risk behavior, like she has multiple sexual partners, history of recurrent PID, history of drugs, IV drug uses, then you need to ask about that also. Then if she has history of pain during sex, then you need to ask her that for how long she is having it, is it primary or secondary, and what has she done so far, how it is affecting her relationship. Then go to her family history, family or person history of cancer. Sometimes they will bring someone whose father had this prostate cancer or the mother had this breast cancer. So in that case, you need to see that she is not having any BRCA1, BRCA2 type of thing. Okay, she is not having any hereditary cancer syndromes. Again, family history of diabetes, hypertension, TB, bleeding disorders, VTE, or having fibroids. Then family history is non-significant in cervical cancer or prolapse patients. So, but family history you are going to ask about all cases, all the patients in all cases, because they may give you some clues. I will tell you in a while about that. So how you will summarize? Mrs. or Miss so and so, how many years old? She's perimenopausal, postmenopausal woman um, with para, and how many are living, and she has reported with complaint of, and then very important to mention from where she was admitted, and she has any comorbidities or not, and she has symptoms of this one, and the exam we are suspect it has been suspected that she is having this lesion when because she has risk factors like this, probably due to this thing. So my provisional or differential diagnosis is this one. If you can't reach one diagnosis, that is even better. Mention 3-4 points and you can see that we can reach the diagnosis with further objective testing. So at that time you will say that you are basically reading this history for this summary for the patient and for the examiner. So ask the patient if you have any additional questions or you want to tell me something additional at this point. If she will say yes, then you will ask her, yeah, please tell me what will you like to tell me now. So that's how you're going to take the gynae history. So any questions, any problems so far? You have any question, anything, you should ask about that. No problem at all. So similarly, yeah, okay, that's good. Because this is just the repetition. We are just revising because we need it for the long cases, and even in the short cases, you on 2 stations you are supposed to take history mostly.
So,
Yes, doctor.
when we have time to ask about all these details, I think time is very short.
You can spend like you should think that you have 15 minutes with you, okay? So because this RCPI didn't tell so far that how many minutes can be spent on the history. Before we knew that 20 minutes. So my opinion is that they will give you like 20 minutes here also because 5 minutes are enough. But you should try to finish your history in 10 minutes. That's why that your exam is on 22nd November, right? So every second day or every third day, you should practice with this history taking. Okay, just talk. That's why I told you that I want all of you to tell me about the points in the history, like the small children will do. That these points are important. So basic thing is practice. Like when tomorrow you go to your clinic, I know that you must be taking nice histories, but you should try to include any points. If they are not included in your routine history taking, then what I would suggest is that mention these points and ask these questions so that they will automatically come to your mind once you will go for your long case. Long case is very important. Whatever the patient is telling you, that's fine. But if you are going in a good sequence, then you are making a good impression on the examiner. Okay? So to pass the long case, you need like 60% marks. So you can do that. Don't worry. So,
So
because,
the
yeah,
the frame يعني like it's 10 minutes for history and 10 minutes for examination and then 5 minutes will be
no,
discussion with the examiner.
10 to 12 minutes for
And
history taking, only 2 minutes for the examination. So you will do, because you're not expected to do full examination, just general examination. Wash your hands or tell her that my hands are clean, okay? Or you can take this sanitizer with you if they will allow you. Just simply apply that on your hands to save your time. Take permission that from the patient, do general physical examination. What you have to do, just look into her both eyes one by one, ask her to that open her mouth and stick her tongue out, and then look at the tongue and the cavity. Then go to the heart, look at her hands, compare her palms with your palms, ask her to raise her knees, bend her knees, and then see that she doesn't have any edema. Just press on the shins of the patient, and then you can say that she has edema or she doesn't have. Then ask her, can I listen to your heart sounds? Put your stethoscope on the area of this left ventricle, and then after that put your stethoscope on the right side of the patient to hear and listen to this lung sounds, and then ask her that, can I see your abdomen? If she will allow, okay. If she doesn't allow, then don't expose her, just put your hand on the fundus, and then take this tape and measure the fundal level. And polyclips, you can do all of these. It will not take like 2 minutes, or at the most it will take 3 minutes, so 15 minutes have passed. Okay, intimate examination you are not doing. And then you have to present everything, the findings of this history, and you will summarize the history, and you will summarize findings of general physical examination to the examiner, so it will take another 2 or 3 minutes. So by doing like this, following this pattern, you will spend 18 or 19 minutes. So then it will leave 5 minutes or 6 minutes for viva. So basically the examiner is going to inspect that how do you deal with the patient, how do you communicate, how is your conduct, do you take questions from the patient. So that's all. So maybe duration of the viva will be even less, because in the short circuits, in the short cases, they have asked you about many conditions. Okay, so here they will just see that how do you take history and how do you do the examination, can you summarize. And if you can't reach at a full diagnosis, that's okay, don't be upset about that. So that's why I'm telling you that now the history taking is even more important, because the examiner is watching you. Okay, so then in the end it is up to them that they want to ask you like one question, two questions, three questions, and then they will ask you to leave. So say thank you very much and leave. Collect your things, say thank you to the patient, and then at this point maybe the examiner will take you out of the room, or maybe you will stay, because they don't like to ask questions in front of the patients. So that's why history taking is very important, and practice for that. Okay, and then in the examination I have seen certain things, like if you will start examining your patient while you are standing on the left side of the patient, that is a wrong practice, right? We have to go to the right side of the patient. That's why again, we have just talked about the examination, but again I'm telling you about the gynae examination. So take consent that, can I please examine you? Then go to the right side of the patient. You will say that my hands are clean, or you will say that I just take a little bit of, small bottles of sanitizers are available. Just take one with you. It will save your time, because you don't have to go to the toilet and wash your hands, because it will take like 1 full minute or 1.5 minutes. Okay, and the time is limited. So better to take a sanitizer. Explain the procedure. Take informed consent. Stand on right side of the patient. examine her in the natural light and maintain privacy of the patient. You will say, tell the examiner that I will put a screen and examine her, or I will take her to the examination room, but here I don't have this option. And I will examine her in the presence of a chaperone. And then request, you can ask the patient that can I look at your tummy. Then you should say that are you comfortable. So you will say that this patient is lying comfortably in her bed, she is conscious, fully oriented to time, place and person, she is of average build or whatever is your impression, she looks malnourished or she looks wasted. And her BMI, you will ask her what is your BMI. If it is a case of ovarian hyperstimulation syndrome, you will ask her that what was your weight this morning and what did they tell you about the size of your tummy. So she will tell you, and you should say that she has told me that this day today she weighed this much and the abdominal size was this much. And does she have any pallor, any bluish discoloration, nails are fine, any edema, any palpable lymph nodes. Vital signs, you will say that I have asked about her and she says that everything was fine in the morning. Any other features of any like chronic condition, she's wasted, she has other problems, if she volunteers. And if she does she have any hirsutism, um, does she have any trunk or obesity, no signs of malnutrition, doesn't seem anemic, put your stethoscope with consent of the patient. Now I need to listen to your heart and sounds and lung sounds. Okay, so you will say that heart rate and rhythm are regular, fine, S1 S2 audible, no additional sounds, and respiration is fine, no added sounds. Mention all negatives also. Yeah, yes please.
Sorry, Doctor.
Yeah,
Do we need to say it also correctly? Because we are not familiar with abnormal heart sound numbers in case it is something like that. It's, if we cannot recognize it,
yeah, don't worry about that.
like if
Yeah,
cardiac patient or
yeah.
something.
You will say that I can listen to S1, S2, and I can't appreciate other sounds, okay? Because that is not your job. You're not supposed to do that. Just tell that you are hearing the regular sounds, okay? Like that. So that's why I told you that you have to stay honest, and then you have then another thing. They will never ask you questions about an unstable patient, okay? So these cases, these are inpatients, but their condition is well controlled. They are quite stable. That's why they are answering your questions, because nobody will ever bother a sick patient. So you are not going to see anyone who is critically ill. All patients are going to be stable. Okay. So you can say that I can listen to S1, S2 because these are like dup dup, these are normal sounds. So no added sound, no abnormal sound. Okay. You are not allowed to do any intimate examination. You will not say anything. Then you can take permission from the patient, look at her neck. So what will you look for? If you are examining her neck, what will be your question? So you will ask her, yeah, you will ask her to swallow her saliva, and if you can see anything moving up and down, then you will say that she has a palpable mass. So then you need to ask her what else you will ask, because if she will have any,
Ask her to swallow.
yeah, yeah,
We will
can
ask
you,
her to swallow and receive any bulge, any
yeah,
bulge veins, any bulge lymph nodes.
yes, you'll do that. You will ask her that just swallow your saliva, please. Can you please swallow something for swallow your saliva for a while? I need to see that nothing is wrong with your neck. Then you will say it's fine, okay? Then again ask her, can I can I have a look at your tummy? So if you will find again, you are standing on the right side, you are covering her, her privacy is maintained, and you will inspect, and you will say that abdomen is distended, is it uniformly and generally enlarged, what is the general condition, what is the color, and is there any mass visible, if the mass is visible, is it regular, irregular, and then flanks are empty, flanks are fine, or you can say the flanks are also full if in case she has some ovarian mass, and what is the position of the umbilicus, this is central, this is deviated, or what, and then are there any scars, if there are scars then make a point that you are mentioning that this is a longitudinal transverse or what. Then are there any visible pulsations? Because if your patient has an ovarian mass and it is causing pressure symptoms, then your patient can have engorged veins, so you need to comment on them. But you are not going to look for everything. Just we are concerned here about the mass. All of these things you cannot do in like 2-3 minutes. So if you have a mass, tell them what is the size, what is the size, is it extending? Then you can say extending from pubis to the sternum. What is the shape, margins? They are regular, irregular. Our margins are seen well, and the surface appears to be smooth, regular, nodular. This mass moves with respiration. So it is there any tenderness? Because if the patient is experiencing pain, they will never ask you to touch her. Okay. But if she is acting, she has been directed like that, then you can say that she feels pain on touching. She has mild tenderness, no rigidity, no guarding. You should mention all negatives also. Then for the liver, you have to do percussion on the right side. Just you're just acting. Just put your hand and hit it with the middle finger of the other hand, and then you will say dull to percussion. So not enlarge or anything. Then you will confirm the same points. Is the mass moving, not adherent? And then dull to percussion, is there any dullness? Because in cases of ovarian hyperstimulation, you will have a dull percussion note because patient will have ascites. Can you listen to the bound sounds? Are there any bruise? Because if they have highly vascular tumors, then you can listen to that one. Pelvic examination is not allowed. So in the end, you will again say that, again summarize like that. All these examinations you can mention that this patient needs speculum examination, but I will not do that in the exam. This one needs digital examination, but I will not do this because this is not allowed here. So we are not going to do cusco speculum examination or bimanual uterine examination or rectal examination because it is not allowed. So you can say that I would like to do other examinations to read some diagnosis, but this is not permitted on the exam like that. Okay. So you can mention, like if you are suspecting that this is a case of endometriosis, and then you can say that if in the real life, if I will examine this patient, I should be able to feel nodularity or thickening of the uterosacral ligament like that. Okay, now I will see that this is slender or not. So in the end, you will say that, so here we have a 55-year-old. This is just an example. Postmenopausal woman with third-degree uterine prolapse, and she has a rectocele. She is giving that history that she has a rectocele or this thing, or you can say that this is 30-year-old woman who has abnormal uterine bleeding, so maybe she has a fibroid. So you are going to mention all positives and all negatives and mention all the points. Okay, that's how you're going to close your history. Any questions? Any problem?
I thought
Just welcome. Welcome, please, one by one.
if we don't do the vaginal examination, how can we say the degree of the prolapse?
Yeah, 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 that's a good question. These patients, they will have full information on their condition. They will tell you that at the time of admission, I was examined and my doctor told me that I'm having these problems. Okay, so then you are going to present to the examiner that this patient is giving. She has just given me this information that she was examined by someone at the time of admission, and it was found, okay, during examination. So I'm mentioning that. So you will give indirect information that this patient was seen, and this was the finding of the examiner, and that's why I know about that. And anyhow, now it is more easy because the examiner is sitting over there, so he will know that the patient has told you, but you have to present all information to the examiner. That is the point. Okay, it's not hard, but I usually put lot of emphasis on the long cases. Why? Because they make the main bulk of your exam. You have done very well on the short circuit, but God forbid if you have lost some marks in the long case, no one is going to pass you. That's why it is very important. Do your best. First of all, as a doctor, you are being tested in your clinic, on your ward rounds. The juniors are asking you many questions, the seniors are asking you. So in the exam, you're just going to mimic whatever you are doing in your daily life. So don't be upset about anything. And my advice is that reach your exam venue well in advance, like at least 1 or 2 days before your exam, so that you don't have any jet lags, don't have any hangovers, and then sleep well. On the day of exam, take a good breakfast. Okay. Then reach the examination hall on time. Make arrangements for reaching there on time. Sit comfortably. You should know very well on which station you are going to start your circuit. And why it is important to take rest before the exam, because you will finish the circuit. Already you will spend like 2 hours, and for 1 hour you will be waiting and listening to their directions, that how they will proceed. After finishing your OSCE stations, you will go to the hospital for the long case, and you will spend like 1 or 2 hours, because usually they will take 2 or 3 candidates, and once they will finish, then they will call the next candidates, because they don't have many examiners. So now you can imagine that it will be already like 3 o'clock or 4 o'clock in the afternoon when you will finish your OSCE. So when did you start? At 7 a.m. And when are you going home? At 4 p.m. So you can imagine that how much tiring and demanding this thing is. Okay. So still you have like more than 1 month in hand. So do your best. So first of all, you should not panic at all, because that can ruin everything you have done so far. So stay calm, focused, and you can do it. Don't worry at all. Okay, any questions? Any problems?
Doctor, the findings, clinical findings are not correct. Like we cannot make a breach caloric prognosis or mass. We
Yeah.
cannot point out that there is fibroid or cyst.
Yeah.
Then there is problem.
No, not at all. You can say I cannot appreciate the lie of the baby, because I cannot feel the head of the baby. Okay, like that. Be honest, because maybe this is transverse, maybe this is like oblique lie. That's why you are not feeling that. You have to be honest. You have to be frank. And these examiners, they are very helpful. And some of you have done your MRCOG also. In MRCOG, the examiner will never give you a clue. They will never interact with you. They will never smile. But you will see that the Irish consultants are totally different, especially during exam. They are quite reassuring. Of course, they will not tell you that they are passing you or they are failing you, but their conduct is very good. I remember like 5 years ago, there was an examiner who was very harsh with the candidates. And trust me, he was an old senior consultant, but one candidate cried and she reported him, and during exam he was removed and banned, and he faced an inquiry. So Irish people, their conduct is really very good. You will not feel stressed out, or you will not feel any pressure. Anything is negative, tell her I can't appreciate it. That's why the ultrasound machine was invented, and that's helpful. Don't worry at all. What you can do is great. What you can't do, you can take help of other objective testing. You can always take a second opinion. If you are stuck during the OSCE or during the examination, you will say that since I can't reach a conclusion, so I will take consultant input. They will be very happy that you are keeping your patient safe. You are not just experimenting, and you are taking senior advice. Okay, don't worry at all. Just relax and study well. Okay, so I think we can have a 15 minutes break, and then you are all are going to start stations. Okay, we'll start with our first circuit of the day. So 15 minutes, and then please log in again. Is it okay?
Yes, doctor, that's fine.
Okay,
Thank you.
dears. Thank you, dears. So take 15 minutes and then come back. You will have to log in again. Thank you.